Now we'd like to focus our attention on how we can prevent pediatric behavioral health crisis. Our next panel, Moving Upstream, School and Community Interventions, will focus on the work of 3 organizations that have implemented community-based programs. Shella Dennery is the director of the Boston Children's Hospital Neighborhood Partnerships Program, a school-based behavioral health program in the Department of Psychiatry and Behavioral Health Sciences at the hospital. Maureen Donovan is the director of school-based service at Heywood Healthcare. She oversees the youth telebehavioral health program. And among many roles at the Boston Medical Center and the Boston University School of Medicine, Dr. Michelle Durham is the Director of Clinical Training for the BMC Transforming and Expanding Access to Mental Health in Urban Pediatrics, or better known as Team Up. I'd also like to introduce Danna Mauch, the President and CEO of the Massachusetts Association for Mental Health, who will be moderating this panel. Come on up.
Thank you very much for the introduction. I'd like to thank the Mass Hospital Association, Steve, Lee, Wale, the Planning Committee, I see Amara there, for your leadership on this critical issue and the challenges before us, which I am the eternal optimist and I know are solvable. As Dr. Churchwell said, there's been longstanding underinvestment in the behavioral health arena, not only in our children, but in the resources that drive our ability to respond to their needs, whether that's rate structures or the workforce. And we can and will do better at this. We're here today to talk about upstream investments that can make a difference. Many of you here know that I and our team at MAMH and our colleagues in the Children's Mental Health Campaign have been champions of pediatric behavioral health urgent care. Today we're here to talk about interventions, and we have 3 leaders with us about what can be done where kids most often appear in their primary care settings, their pediatric settings, and in their schools. You know, the rates of anxiety and depression for kids in Massachusetts have increased by more than 50% between 2016 and 2020. 67% of parents surveyed during the course of the pandemic indicated that their child or adolescent's behavioral health and well-being had been disrupted during the pandemic. But as many have said before me today, these are problems that existed and have before the pandemic and have deepened. So I'm really glad today that we have people working on the front line who can talk to us about solutions that work. I'd like to ask each of them to spend about 5 minutes talking about their intervention, what opportunities they had to implement this, who some of the champions and partners have been, and then we could have some cross-cutting discussion about some of the strategies for implementation and sustainability that will allow the rest of us to adopt these practices and grow the care response to children, adolescents, and their families and caregivers. Thank you. So, Maureen, would you like to speak first?
That's great. Hi, welcome. I'm very excited to be here. I have been a teacher for 20 years before I moved into this, so people, big adults, scare me a little bit. So I'm going to do my best to hang right in there. I want to thank you so much, Mass Hospital Association and Boston Children's. I always have an admiration for Boston Children's, though I live out in the rural lands. These were Dragons B, I was told, where I live. Thank you for inviting me. My name is Maureen Donovan, and I'm the Director of School-Based Services for Heywood Healthcare, located in North Central Massachusetts and the North Quadrant. Rural by Mass standards. I'd like to introduce my partner, Christina Cutting, who is now the Youth Telebehavioral Health Program Manager, sitting in the second row, wave. And she oversees this program now as we have moved into some telemedicine work as well as school-based health center work. So I'm kind of flying around the top, and Christy's drilling it right in on the Youth Telebehavioral Health Program. In 2017, we took a chance and implemented the telebehavioral health program in our local school districts. Our survey of the social determinants of health indicated our children and adolescents were in need of behavioral health services, and our local behavioral health providers were overwhelmed. I'm saying 5 years ago, right? I'm not saying this current crisis. This is a look back. This is still the case, and though I realize we all see that we have a child-adolescent behavioral health crisis currently, we had one many years ago. Our local provider of behavioral health services at present has a wait list, at present time, has a wait list of 200. So I'm happy we had the foresight to begin this program to supplement the need. A public thank you to the Health Policy Commission for taking a chance on us and letting us pilot this way back in the day. HRSA for the $1 million gift, I call that a grant that let us get going and fiscally support us to begin our great adventure. And Heywood Healthcare, who a little small hospital organization out in our area, who has stood behind us and allowed us to move forward even as grants dwindled. So they stood behind us. They didn't think we were going to be here. They pretty much said after the HRSA grant, and I refused to allow that to happen because sustainability is key for us. And we can't take services away from children, ever. To our state representatives and senators who supported us and who actually recognized this program to be a model to be replicated across the state. How cool was that? That was not, no clue we were going to do that. We are in 5 school districts, and we offer telebehavioral health services, tele-ACRA services for students identified with co-occurring mental health and substance use disorder, an AMP mentor program for at-risk students, and the community health workers are also available to any students in the school building who need help with community resources, which include food insecurity, housing issues, the list goes on and on. Why did we do it, and why does this work? We needed to meet our students where they are. We needed to meet them where they are every day. A community health worker works in the school implementing the program as the therapist sits remotely and zooms in to school to deliver behavioral health services. Currently, we have 8 therapists, 4 LICSWs, and 4 LMHCs. The community health worker manages our electronic health record, schedules student appointments, tracks our sessions, calls students to the session, coordinates the student appointments with teachers and families, assists with community resources for the student and family, and collects program data. I would not be sitting here without my community health workers. And that's a discussion for later, very quickly later. But my community health workers are key for the success of this program. For example, at the end of September 2022, we have completed 7,829 behavioral health sessions with enrolled students in the past 3.4 years. And we have wait lists. We brought access and addressed our rural transportation issues. We do not have Lyft or Uber in Athol, Massachusetts. We do not have it in Royalston and Narragansett. There are no Lyfts, there are no Ubers. So we allow students to access behavioral health in the school setting without life interruption and without stigma. We have created a safety net for our families and a team that provides wraparound services and program coordination in the school setting. And we are embedded, and our teachers like us, and our guidance counselors like us, and we work together, and our CHWs wear badges that say Heywood, and they have their school picture badge collectively, right? They're part of the process. School-based telebehavioral health is seamless and simple, and everybody, we were Zooming way before COVID. We know the Zoom people because they had never done anything like this from California, and they were working with us collectively to start this program. So we were doing this very long time ago. So when COVID hit and everyone said, oh, we're Zooming, I'd say, well, that's old school. We've been Zooming for a while. Satisfaction surveys indicate that families and students gave us a 92% positive feedback. Students like it, families like it, and it's a win-win. Now, that's all the good stuff. So I want everyone smiling as I move into my that said paragraph. That said, we have our workforce challenges. Sustainability is tough when in the eyes of insurance companies, and if you're an insurance company out there, I apologize profusely, but I'm gonna say this. Community health workers are not a billable service in the state of Massachusetts. If they could be a billable service, then I would have a sustainable program. But for some reason, that's not rolling down the road as quickly as I wish. Christy and I have spent time lecturing about the program at Massachusetts universities and hoping our future clinicians, behavioral health clinicians, will see the value in telebehavioral health, and we are hopeful universities are developing training curriculum in the telecounseling field. The key is not to give up, because all who know me and my mantra, and I can be very irritating at the State House, and I can be but I always say this: we are here for the students, we are here to make a difference, and we may not know in real time, but we are making their lives better and giving them the tools they need to thrive. I believe we will have successes and challenges, but I'm also one to know that through these, we will continue to learn lessons, move our program forward, and support behavioral health in our rural school districts. Christy and I are here. If you want to meet us and learn more about our program, we have an open door policy. I always have. And I really, again, want to thank you for letting us showcase our program here. Thank you so much.
So Shella Dennery is going to speak to us next about her experience in forming partnerships between Boston Children's Hospital and schools in the city of Boston. And in full disclosure, I had the privilege of being on the board of one of the schools. I still am actually on the board of one of the schools where Shella provides her services, and I can attest to its value.
Well, thanks. So it's an honor to be here on the panel with my colleagues, but also to see so many familiar faces in person. I'm thrilled. As shared, I run a school mental health program at a Boston Children's Hospital. We are on our 20th year. It is my 20th year. I was the first hire, and I hope for 20 more. Woohoo. Yeah, thanks. I'm going to share a little bit about what we do. We've been really fortunate to have combination and blended funding from the hospital to money from Boston Public Schools to philanthropy to be able to do school mental health in a way that's needed. And so we have for 20 years been able to be really creative and be really innovative in doing group counseling, having open door policies, doing prevention lessons in the classroom, teaching kids about help-seeking behaviors. And I think, you know, over time, we've really realized what is needed the most, and how much kids actually do need a place that is way more than a 50-minute hour once a week. And now I think we've built upon that. And so I'll tell you a little bit about the things we're doing. So we're on the ground in schools in Boston. And then we've been really fortunate to work at the district level in the city. They have 121 schools, 57,000 students. And so we've worked with them on working with our psychology department to do a comprehensive behavioral health model across the city. We're now working with our social work department, which is newly formed. There's 175 new social workers in Boston Public Schools as of the last 2 years. So we're helping provide training for them. And I think the plug I'm going to say there is right now we're talking a lot today about workforce development. And I think we're finding people in certain roles, and we're actually staffing in schools quite well, but we're not providing any job clarity, we're not providing supervision, and we're not providing training. And so we partnered with Boston College, we're partnering with other people, and I think Dr. Samsel, your comment about burnout and exhaustion, I think is even, you know, sort of more enhanced when people don't have the supports they need to do this work well. So I'm sort of seeing staffing models happen and people be in positions but not have the support that they need. And so we also work with the district on a student success team initiative to sort of help them think about referrals for kids and how to do that well. There's all sorts of best practices. We actually know them. We don't need to make them up. It's about really having the capacity to put them in place. And so being a thought partner, being consultants, being trainers, really supporting the district in Boston has been our focus. And so those are two of the main things that we've been doing. We also work with the Children's Mental Health Campaign to help really think about ratios for schools statewide. This should not depend on your zip code. It should not depend on where you live and go to school as a kid. You should have access to social workers, guidance counselors, school psychologists, nurses. You should have a team in every building in the state. And some of these issues that we've talked about earlier today, I think we're talking about prevention. We could do so much in our schools if we actually had the infrastructure to do some of this, upstream work that we've been working on for many years, but we often don't have enough support. We've been doing this, we've been doing training of teachers. We've done learning collaboratives. We trained 25 different schools in Boston over the last 6 years. And what we've done is now taken our trainings and put them on the web, and we've open sourced them. They're free. They're nationwide now. We have a course of 6. It's about mental health for educators. You won't be surprised to hear that teachers have no training in this. And we're thinking a lot about the adults surrounding kids. I'm always thinking about how do we make sure that they're feeling resilient in what they're doing and what kids are bringing not only into our hospitals. Chase, I'm sorry to keep quoting you, but like you brought up acuity. We're seeing kids in the classroom having such bigger struggles than they've had in the past. We used to worry about 2 kids in the classroom. Now we're worried about half of the kids in the classroom, and the teachers are feeling very ill prepared. So we have a ton of workshops for educators, and they are online, but we've been thinking about different things. We've done a documentary on anxiety for parents. We've been doing webinars. We're trying to think about, and we just did a podcast on sort of thinking about how to be resilient in the face of all of this, and really thinking. We love the kids and the family work, and we're always about centering child and family voice, especially in urban Boston where parents aren't often heard. But we really are trying to bolster all the adults around kids, and I think that's really, it's really exciting to be here today and to hear about all the ways that people are thinking differently about how to do this, because I don't know who said it, but the time is now to invest in this and to think there's so much opportunity. There is roadmaps to do this better and well, and I think I'm pretty encouraged and excited for what's ahead.
Thank you, Shella. So in talking about getting upstream, it's hard to think about where to get more upstream than in pediatric primary care. We're fortunate in the Commonwealth that we have for a number of years now had a mandate that started in the Mass Health program, but this benefit has migrated to private insurance as well to do screenings annually as part of the well child visits for behavioral health. And in fact, the percentage of kids in Mass Health who get these screenings has grown over the years to exceed 90%. And that opportunity is not wasted in the programs that Dr. Durham is involved with, where she, in her role as a clinician, an educator, a scientist, works at the intersection of our largest safety net health system and community health centers to enrich primary care. And I want to compliment the Team Up program, which she's going to talk about, for the work they've done to document their experience, to share that work through a learning community with the rest of us, and to really promote expansion and broader adoption of their practices. So.
Thank you so much. I'm also very happy to be here, and a lot of what Maureen and Shella have said, I think, aligns with what we're doing in Team Up for Children. So I'm a child and adolescent psychiatrist. I do practice clinically at Boston Medical Center in the outpatient child clinic, and then I also see the other side in the psychiatric emergency room. And though we have this continuum of care, I really do believe fundamentally as a child psychiatrist that we really need to focus on prevention and promotion, and that, yes, some kids will need that acute care in an emergency room or inpatient locked unit, but what can we be doing early on to prevent this? And obviously at Boston Medical Center and in our federally qualified health centers that we're affiliated with, we are working with marginalized communities that are on the margins, that folks generally don't want to talk about, maybe don't want to serve, and don't have a seat at the table. And so that has been our focus. I think that increasing access to care and providing care for folks that we're seeing in our FQHCs is really about bringing them away from the margins, making sure they do have a voice, and making sure that they have equitable access to mental health treatment that is evidence-informed, and that they have access to mental health clinicians, that they typically won't have long waits, as we all know, to get there when you don't have the means to do it. Earlier, Tashina, said a lot of things that I think resonates with what we're trying to do in the Team Up model, and thinking about how do you really foster community and connection, and really think about demystifying, essentially, mental health in some capacity, that it's sort of scary to have to think about going to an outpatient child psychiatrist or another clinic for care in the communities that we're serving. So predominantly Black communities, predominantly people of color from all ethnic and cultural backgrounds, and very linguistically diverse. So we partnered pre-pandemic as well with 3 community health centers back in 2015 to start developing this model. It's a true co-partnership with the FQHCs and clinical leadership there, as we call clinical champions, that consisted of a pediatric primary care provider, a program manager that sits in the FQHC, as well as a behavioral health clinician, whether that be a psychiatrist, some FQHCs have a child psychiatrist, or a clinician that was LMHC or LICSW trained. And with that partnership of these 3 community health centers, 3 people at each health center, and the BMC team really started developing a model of how do we do this work. Pediatric primary care providers have longitudinal relationships with kids and families. They see them. When family has an issue, they're going to go to the clinic to get help. How can we get help right where they are? And so that work has been funded by philanthropy as well over now almost 8 years of doing this, initially by the Smith Family Foundation. Now the Klarman Family Foundation has joined, and we are in 4 more health centers, so 7 in total, all the way down to Greater New Bedford and Brockton. And if you know anything about Greater New Bedford and Brockton, a lot of folks too that are undocumented, so aren't able to access a lot of the CBHI services and other services in the in-between between outpatient and locked. That's it for those folks. So those are really all of our target populations. And what we've done over the last 7 or 8 years is that through our FQHC partnerships is that every health center now in primary care has community health worker. I also resonated with your comment, Maureen, that we think that's key to our model. The community health workers are bilingual, bicultural, and or from the community that they're serving. So the community health workers that we had in Lowell Community Health Center when we were in Lowell, very different from the community health workers that are in Greater New Bedford. I think they're a key part of the care team. We are intentionally called Team Up for children because we do believe it takes a team in the primary care setting. It takes community for folks to get better. And as we know in healthcare, the higher you go up the chain, the wider it gets. And our families don't connect with all the primary care providers in these settings. They just don't. And so how can that, it's almost like a cultural broker, how can that CHW bridge that gap? And understanding the needs of the parent, the child, and the family with the mental health clinician and the PCP in primary care. So we also have clinicians embedded in all of these settings, whether they're LMHCs or LICSWs. A few, I'd say only about 2, have child psychiatrists. Dot House, for example, has a child psychiatrist that's there. But if they don't, they utilize folks like me on the care team and another colleague at BMC that we have sort of our mini MCPAP. So those 7 health centers have access to us immediately. And I think part of that is always relationship building, right? I mean, they're much quicker to contact me now via text, email, or phone to talk through a case and really think about how can I help this family from my role as a pediatrician as a part of the clinician work and the community health worker work. So that's the team at each health center. I think the other big piece of this is that we have a huge team on the BMC and BU School of Medicine side, from an economist on our team, thinking about how are we saving dollars ultimately, are people less likely to go to an emergency room, because we are at the stage of prevention and promotion. Mild to moderate illness is being treated there, that they don't need to go to an urgent care or an emergency room for services. Thinking about this from an implementation point of view, we're really looking at the EMR data a lot. So we have full teams on the health center side too. Their IT department is getting paid to help us look at all of that data, restructured what the templates look like in the medical record system, and really guiding the pediatric providers. So there was a mental health issue at your visit. What did you do? That is literally a question within some of these templates. And then did you bring in the clinician or the community health worker? What was the next step? The clinicians can provide therapy within the primary care setting. And that's where me and a lot of my colleagues on our team have developed a full 18-month learning community for both cohorts that we've had now on training the whole team. I think I've been a training director in my other life at this point, and pediatricians don't get trained in this. That is not a part of their national requirements. So those who end up going into private practice or, having some type of clinic, some of this is new to them. And so we are really helping guide them to what does it mean to start, a medicine for depression or ADHD or something else that's happening for this kid. And so we have a whole online course that they can take at this point in the initiative for some foundational skills. That's not only for the pediatric providers, but for the clinicians. Many of you in the room may be, social workers who the integrated setting is something new. It's different. It's in a medical model, essentially. And so how do we also prepare them for what may be different than a traditional outpatient mental health setting? And last but not least, the community health workers are an extension of our workforce. And so we want them to be able to engage families, provide psychoeducation, and do care coordination. You often hear community health workers as only care coordinators, and that is not what we're doing in Team Up. We really want them to be sort of cultural brokers. We really want them to understand some key concepts in mental health. What does that look like for kids and families? And how can you better prepare the parent and really help support the parent in advocating for their child too and the needs of the child and the family? Last but not least, data to this point says that, in all of our health centers that the kids are meeting with a behavioral health clinician the same day. That doesn't happen. Most practices, there's an issue and the kid has to wait weeks to months to years to see a behavioral health therapist. And so that is happening same day. The other big thing is that we have seen that primary care providers are have less burnout. They have the support of their team now that they knew probably all along prior to this, like, I know I need to do something and I don't even have the resources. I don't know where to send this kid. And so they have reported less burnout as well. And last and not least is that, I think our funders were initially worried that all of a sudden all these kids were going to be on medicine. And that is shown not to be true, it's steady. We haven't had all of a sudden these kids with all sorts of medications on board. They're getting therapy, they're getting connection to services and community resources and medicine in addition if needed and indicated. And so that's some of the highlights of what we've done to date. But there's a lot of moving parts in Team Up, a lot of people that are working to essentially, how do we get kids early on to get the help and support that they need within the primary care setting?
Thank you very much. So I will just say one thing, because we are out of time for our panel, that you've heard a lot of discussion here from these three examples of great programs that help us get upstream. And each of them features integration on behalf of kids where they are, kids and families, is integrating behavioral health resources into natural settings, be it schools or pediatric primary care practices, partnership, teamwork. I will also say that with regard to sustainability, that in the last couple of years, we have seen significant steps taken that would help to not only sustain the programs that they are operating, but to make available for broader adoption these programs. And that is on with regard to the efforts that have been taken to permanently remove in legislation last year any barriers to the ongoing use of telebehavioral health in the Commonwealth, removing administrative barriers and cost barriers, work to expand the investments in schools, in behavioral health staffing available to schools, and to make more of those services billable, and the work with the adoption of the CBHI benefit by private insurers to make it more possible to do the kinds of early intervention that Dr. Durham's describing, and also the adoption of the collaborative care codes, which any of you are health professionals here, I urge you, please start using those codes. They've been in place for a year and a half. Uptake is slow. I know your sites are using them, but there's really is an opportunity to pay for this work that's being done. So thank you.